Let's carry on with my co-chair, George, to the next speaker.
So next speaker, I don't think I need to make any specific introduction on Professor Hohenberger. You all know that he's the person behind this CME idea, which is the TME equivalent for colon cancer. But although TME is well adapted between surgeons, there is a debate about the CME. Professor Hohenberger, please come to the podium and tell us about the CME concept, especially on this specific area. Transfer.
Okay, thank you. So, Mr. Chairman, thank you for your kind introduction. And Evangelos, I want to thank you for your, long-lasting friendship. You told me I had missed the first meeting here in 2004, and since then I've been always, and it's always a great pleasure, and we enjoyed your hospitality. Well, you asked me to talk about transverse colon cancer, which is a specific site, and maybe the complexest one of the CME story. And since we published this paper in 2009, there are close to 900 citations, and some are dealing with surgery for transverse colon cancer and CME, mostly to compare open versus laparoscopic surgery, is it feasible or not. And there are just 4 papers from 3 institutions which touch the most important aspect, which is the lymphatic spread in transverse and colon cancer and those of the flexures. And finally, about close to 20% of all colony cancers account for transverse and the flexure carcinomas, and you have to include them into the concept of transverse colon surgery. So it's 1/5, no more, but enough to make a lot of mistakes. And the question is, what is the probably extent of resection for cancer like that? This is a photo that Phil Kirk has sent me recently when I asked him to send me different kinds of qualities of CMEs, and it demonstrates cancer of the left transverse colon stenosing, and this is probably here the middle colonic artery, and maybe here elsewhere the left descending colonic artery, and you see that the gastrocolonic arcade is removed, as Sigmar Stelzner showed a similar specimen from his institution. And finally, also the lymph nodes along the inferior aspect of the left pancreas has to be included for good reasons. Well, now I will present you some oncologic outcomes of curative cancer at that site, and I will start with the local recurrence. This is a local recurrence of the transverse colonic resection at the root of the superior mesenteric artery. This may be probably the root of the middle colonic artery even. And local recurrence with colon cancer is a clinical problem. It's much more frequent than most of you will assume, and Annika Sjöwall has published on that. And so I've looked into the literature, and you will find a rate of 20%, even more. And you should know that the decision for adjuvant chemotherapy is just based on extremely poor surgery. And we have to question that in the future, whether it's really needed with high-quality surgery and quality control surgery in trials. So she reported 11.5% from the Stockholm area, and the hazard ratio showed that there's the highest rate of recurrence with flexure carcinomas, almost 3 times increase compared to ascending colon. And there's our data, which we in our first publication had reported. It was close to 10% in stage 3 and dropped now, as we have published in the British Journal, to about 4%, but we have not yet analyzed in detail related to the site of the tumor. But again, this is our survival. And astonishingly, the ascending colon cancer does worse compared to the sigmoid, and the transverse is a little bit better. So even with very advanced surgery, we were consequently applying that. In any case, it is lower than with the sigmoid tumors. And on the other hand, there is data in the literature saying there's no difference, but I think it's just due to the small figures, and so again you see the left colon is doing a bit better than the right, and transverse is again in between. And just this year a paper was published on the hazard ratio compared to survival of the rectum, because you may know rectal cancer is doing now everywhere in the world better than colon cancer, and this is a bit confusing because 30-40 years ago it was right the opposite, and colon cancer did much better than rectal cancer. So again, this indicates there's still a lot of work left and to improve colon surgery. And look at the details, you see almost twice as low. You have to interpret it inversely compared to rectal. So 50% survival of rectal cancer survival with a hepatic flexure. I'm wondering about this low figure because in our department in the 70s, when we performed conventional surgery, so almost no patients survived on the long run with a tumor at the splenic flexure. They all died because surgery was poor and lymph nodes were left behind. Our zero resection was probably lower, and so on. And so I wonder why it's that low. And again, transverse is in between, but again on the right side. That for me, it's quite clear that there's still a lot to do with colon cancer surgery, even nowadays. Now, coming to the consequences, what have we to do to improve that, or what is to do to get optimized results? So, and I will talk about the extent of the pericolic resection and what arteries to be tied and what lymph nodes to be removed. And so you will find these sketches frequently in guidelines. And so you realize for hepatic carcinoma, you have to remove the ileocolic artery, a true right colic artery, as Sigmar Stelzer told already, rising from the supramesenteric artery is, in my experience, rare. So I did really more than 1,000 cases and dissected always the arteries. And it's there at about 5 to 10%, no more. Most frequently it's originating from the middle colic artery. So nevertheless, you have to remove the ileocolic and the middle colic at its root, at its origin, from the supramesenteric artery, and extend the resection to the left, because I will show that soon. You will not find pericolic lymph nodes beyond the distance of 10 centimeters from the tumor to either side. So you have to cut here, you get everything even along the colon. And if when the tumors are shifting to the right, or to the left, sorry, of course you have to extend the resection more to the left. But always again, the middle colic artery has to be removed. The ileocolic can stay behind. And you have also to include the left descending colic artery, but must not remove or dissect the inferior mesenteric artery flush with the aorta. This is not necessary, you can leave it, and you can dissect the lymph nodes even here. And for splenic flexures, the lot concerning the colon is quite similar. Well, and if it's in waiting the descending colon, of course, then you have to transect the inferior mesenteric artery and take these vessels too. Well, but this is not the entire story. The Japanese resect less, and they resect to either side 10 centimeters of the colon, and therefore they create almost segment-like resections like here, hepatic flexure, just the middle colic artery, and you see they include into the sketches the right colic artery too. These are the Japanese guidelines, although it's rare. They didn't really watch the vessels exactly always. And so for right transverse, again a segment and so on. So they perform shorter segmental resections. Their results are similar to ours, maybe lower, but they questioned that now and started the T-Rex trial about maybe 5 years ago, comparing my extended resection and theirs. So they are not pretty sure that they did correctly all the time. Well, but they always did, or almost always, they do what they call a D3 resection, which is equivalent to my central tie. Never use the term high tie. High tie is pretty high and long. So you know that from your MRI trials. So high is long. Well, nevertheless. So finally, this may result in a specimen like that. So splenic flexure carcinoma, 10 centimeters to either side. So the Japanese would do white here, and I included always the next arcade to be sure that the entire field is cleaned. And this has no disadvantage at all. So whether you do a segmental resection or a more extended one, there's no impact on function, nothing. And even not on complications. But if you follow the planes, it's easy, clear surgery. But you see, again, the iliacoelic artery is, a gastrocolic arcade is included, and the lymph nodes along the inferior aspect of the pancreas too. And the question is it necessary? And Sigmar Stelzer gave you the answer already. This is one of the slides from Thilo Wedel. And so, it's finally from the Atlas, and I'm always referencing to Thilo Wedel, and his name is included on one of the next slides. So it's about these lymph nodes. You saw this slide already. It's a very important one. So these are the lymph nodes over the pancreatic head and along this artery. This is what we are talking about. So there's data from just our department. No, this is from Feng. So this is one of the 4 papers on this subject. And they found what they call subpyloric lymph nodes, and these are those over the head of the pancreas. In high rate, but that's what I want to talk about now. Lymph nodes along the greater omentum in 22%, 9 of 41 in stage 3. So 1/5 if there were lymph node metastasis at all. And the other papers from our institution, and you see 3 so small figures, so we need more data on that. So a lot of work to do for you. 3 out of, you see 17, so 1/6 in stage 3. So again, close to 20%. They are much more frequently than you assume. And there's the third paper from Hillerød in Denmark, Bertelsen, published again 8% if lymph nodes had been involved. So it has an impact on outcome, definitely. So, and the reason is, when do you find lymph nodes at that site? There are maybe two reasons. One is invasion of the great omentum, and the second pathway or route is invaded and may lead to distant metastasis, if you want to say. But what Sigmar Stelzer told you, and I've heard that for the first time, and that he says in about 50% you may find these vessels. And he's right, they are sometimes very small, but they are relevant. If you dissect carefully, you may just coagulate a small vessel, but this is an important one because they are crossing what he showed already. Oh. Yes, so these are small vessels crossing. This is a very important slide. So they are crossing from the midgut to the foregut. And you know, lymph node metastases develop along the supplying arteries. And this artery is running to the pancreatic head. And so tumors from here may lead to metastasis along this side, and the same on the left side. So that means you have to divide the right gastrocolic artery centrally. This is the gastroduodenal artery. This is the superior pancreatic duodenal vessels, a bundle-like vessel structure. So you have to divide it here and take down the lymph nodes over the head for the pancreatic head, and you have to skeletonize the stomach, like here. And then you have cleaned the entire field. And again, I apply the 10 centimeter rule. So not to remove the entire omentum, but just 10 centimeters to either side, depending on the excite. And the second point is those along the pancreas, pancreatic head and left pancreas. And so it's well known that there are those over the head for many years already, again from this paper from China, in 1/3 in stage 3, they found lymph node metastasis here for hepatic flexure carcinomas. So quite a high figure. And we found 5 out of 11, so almost, so very close, 40-50%. And the reason is this photo, which is also extremely important. And you have seen already before in sigmoid delta stock. So this is the middle colic artery, the left branch, left colon. And there are 3 to 4 thin vessels running towards the pancreas. And they are connecting inside the pancreas with a transverse pancreatic artery. I know that because I did a lot of pancreatic surgery too. And once I operated a patient in Ankara, which with a huge tumor and a thick interpancreatic artery. And so it was evident that it's the connection. And you see, if you open the lesser sac, this is, by the way, the cranial plate of the transverse mesocolic fascia. It's a fascia. It's covering all continuously running fascia. And here it's transverse mesocolon. From here on, it's mesopancreatic fascia. So, and these are the arteries running towards the pancreas inside to the transverse pancreatic artery, and there are 3 to 4 nodes. One here, maybe here, right along at the root of these small vessels. So, and if there's had not been a chronic pancreatitis before, you have to dissect it. You saw that in sigmoid delta presentation already. So, transection here, split the superior plate and laid on the posterior one, which is coming from behind. This is the section of the left pancreas. And finally, this will result, it has to result in a situs like that, with the pancreas, the uncinate process, the duodenum. So again, it's a continuously running fascia, mesoduodenal fascia, mesopancreatic fascia, including the vessels. And so the mesocolic fascia has been removed. The lymph nodes removed along the pancreas. This was for a right transverse colon cancer patient. And the superior mesenteric vein is cleaned, never stripped the aorta. This was also told already. The root of the middle colic artery, the iliacolic artery. And this is a central tie, flush with the superior mesenteric artery. So that's the situs after a section like that. Well, we need more data. And we must not look at the entire group of patients, because the outcome may be similar. But if you look at the complex cases, like stage 3, T4 tumors, emergencies, and even those with less than 12 lymph nodes removed, because they split the prognosis much more than stage 3. So you have to look into registries, population-based ones. The Scandinavians have the best registries, and they should do that. And so even in your local registries, if you analyze it in more detail, so you will find differences, and this may create more evidences to support that what I've told you. And so secondly, I think there's no argument against doing that. So I think even present data argue for extended lymph node dissection. And you have to do that just to get the material now. So if you never have removed it, you can't present data on that. And I think this is the talks of the next generation. Thank you so much for your kind attention.
Thank you very much, Professor Hohenberger, for your nice talk. Any questions or comments from the audience? Yes, please.
Thank you so much, Werner, for all your contribution to trying to improve the quality of colon cancer. I mean, if you take a few things just from the end, less than 12 lymph nodes, it's not a matter of whether they are removed, it's a matter of whether they are harvested. So it's a combined thing between the surgeons and pathologists.
Yes.
Yeah, and in our country, we don't discuss 12 lymph nodes anymore, because it's public, and the average lymph nodes yield from all sides is something around 22 or 24 lymph nodes. So it's a matter of quality.
Yes.
The only, that in my opinion, I mean, what do you think these three elements of the CME, the right plane, no doubt in my mind that you really should go for this. Then the central tie, do we really do a central tie or don't we really do it? And then my concern, you know, convincing Danish surgeon, that's the gastrocolic elements, taking the gastroepiploid with, you know, for the transverse tumors. And I would like also to ask our colleagues from Leeds, I mean, do the surgeons really give enough information to the pathologists about the, you know, the extent of resection of the gastrocolic ligament, marking it, and specific counting in this area?
Well, a lot of questions, but all
I'm
important.
sorry.
No, all important. You're absolutely right. So, firstly, 12 lymph nodes is still an issue, more or less, and they have the worst prognosis, even worse than stage 3. So even if you don't find the lymph node metastasis, the prognosis is worse than stage
but
3.
that's due to poor quality.
Yes,
so,
but I would say in 80% of this world, it's still standard, even in the United States, or even more there.
yeah, I know, I know, but it should be.
Well, okay, so it should have gone. Well, what contributes most? I think if you add 5% and 5% and 5%, you end up with a reduction of survival at maybe 15%, an increase of local recurrence to 20% or more. So it was not enough looked at the local recurrences. It was thought it's of minor importance, but it's not. So I think I've talked about that with Phil and Nick, and please correct me. I think most important is the plane. The plane preservation is the most important aspect. So for the central tie, so there are lymph node metastases. If you don't, or if you look at the lymph nodes centrally, around 3 to 10%. So group again. So if you add the gastroepiploid arcade and so on, what I said before. So finally, I think the central tie will improve survival, filled by 5%, and maybe a bit more. But again, if we add everything, so we will end up at that. And if you leave, so a high tie, you know that from your MRI studies, then you will find quite a lump of lymph nodes and so on. So I think.
And I'm sure. So it's, in my opinion, it's a process. You can't go for the young ones. You can't go listen to Werner and go home and do everything perfect the next day. It's a year
yes, it takes
long.
Years. It's a learning curve. Definitely.
It's a long learning curve with quality control. That's,
yes, and by well, sorry.
May I ask Phil and Nick? I mean, they are expert pathologists. I mean, when they see transverse colon specimens, how often do they see that the gastrocolic ligament has been removed and marked? They just from a small area in Leeds. I mean,
so we never see it.
Oh, thank you. So is that? So you see, this is.
Well,
I'm not arguing against it.
Yeah, I know, but Søren, this is the point. There's no evidence, because if you have not removed the lymph node, you can't well present lymph node metastasis or find some. So I think some should continue and add this and get.
Exactly, and I agree completely with you. It's just. I won't mention his name. It's a very, very famous British colorectal cancer surgeon. He said, I don't believe in this gastrocolic thing. I just don't believe.
Well, some don't believe in.
Yeah, I'm just. Sorry.
Okay.
Any other questions or comments? Yes, please.
really enjoyed your lecture once again. My only concern is that the reason that the technique is not widely adopted is because of the training.
Yeah.
And the training in the different countries is very, very variable.
Yeah.
And for example, colorectal surgeons, as they are trained in the UK, and correct me if I'm wrong, when they go near the pancreas, they are not very comfortable.
Yes, and
This is an HPV.
and when they get close to the vessels too, I know that.
Exactly. So my concern as a young surgeon is, now that you are retired, obviously,
Yes.
where can we go and be taught?
Well, first you have to agree with the concept, and then you need training. But you know, if you don't do that, the pancreatic surgeons will do that, or transplant surgeons, because they are acquainted with the vessels. Pancreatic surgery, transplant surgery is vascular surgery. So, and you must just accept that oncologic surgery is vascular surgery, and colorectal cancer surgery is oncologic surgery. And you will not be a surgical oncologist before you are able to perform oncologic surgery, which is important in our communication. So then you will talk about the oncologists, sorry to say, they do not more exist in Germany at least, since I was the president of the Cancer Society. You won't be a partner for them. So that's why I have just accept that and find a way to get acquainted and, well, to accept that the vessels are the surgeon's best friend. Not the jewels, but the jewelry, but the vessels are the surgeon's best friend.
Let me ask a question as well, if I may. Do you think that the most important component of your idea is the extension of resection or the removal of the mesocolic package intact along the embryological planes with the central?
Yes, that's what I said. The integrity of the package is the most important thing. And so everything else is just well, it's.
You insist to resect too much.
No, the length is not the point. I think so. This is the question of the T-Rex trial. But I think the contribution of length of the specimen, it's not the length, it's the architecture of the arterial blood supply. This is the indicator for the extent of the longitudinal resection, nothing else, just the vessels.
Okay, thank you very much. Thank you. Yes.
Short question. I'm Dr. from Greece, and I'd like to ask, how do you cooperate with your pathologists, and how do you convince them that you have done the right operation?
Well, you know, my mentor was a pathologist. It was Paul Hermannek, and his office was next to mine. And I brought every specimen, as I had sent it to Phil Kogan next request, to him personally, and said, "Well, look here might be a problem." And so he was a very imperative mentor. And so it's to communicate. It's not just to put something in a bag and let it there for 3 days and ask the nurse to send it to the pathologist without any notes. So this is not enough. But yeah, it's always respect everywhere, respect. And so and it's also a matter of quality control. So they controlled me and I controlled them, and we increased both our knowledge. And so they are acquainted with that. But you have for transverse colon, it's difficult. You have to make marks, set sutures with different colors to get orientation for them, because it's not easy for them.
Do you take pictures in the theater?
Yes, we take pictures, photos in the theater. With a ruler.
The mesocolon can be short or long.
No, just so if you put mosquitoes to the sutures and stretch it and take photos from either side, then it's enough.
And what do you drink in Denmark, Prof. Laver?
Sorry?
What are you doing in Denmark with the cooperation with your pathologists? How do you?
They opened the session.
No, of course not. We have been doing photographs for many years of the press specimen. In theater, but now we have changed it. We use, and we haven't published this yet, a study where all the surgeons were forced to score their own specimen. I think if I were Caesar, I would say every time that you have operated, you should look very cautiously, carefully on the specimen. Critical. Always, you often make minor mistakes. To think about how you can improve it. So we have taken pictures, yes, in the theater. Now we have changed it so that it's done by the pathologist.
Yes, but don't open the specimen.
Of course not. Of course not.
No, it's not a joke. It's common practice.
Yeah, of course not. But I think we have a specific, and Werner knows it. I'm just telling you how difficult it can be. I mean, Werner has been with us. He has been teaching us. He has been training people. But particularly for the transverse colon cancers, people are a little scared.
Yeah.
They are scared. And I tell you, to be honest, I'm not sure. And I think that the majority on the transverse colon cancers are not marked the way it should be. And Bill, you know it, we have just had a workshop also for the pathologists discussing the transverse colon and how we should improve the quality on a national level. And what did you get out of it? What did the Nick did it? You did it.
Yeah, well, you're already doing it very well.
Thank you.
You're already marking up the gastroenteric arcade, and the pathologists are used to looking. So I think you're already ahead of where we are.
Thank you. We are ahead of the British.
But of course, the pathologists must be interested.
They must be
And
interested.
if they find it boring to count lymph nodes and to look at a specimen and so on, it won't work.
But the reason why the pathologists might be bored is if the surgeons are not interested in the quality. I think it's a dual, it's an interaction.
Okay. Thank you very much for your contribution and discussion, but I think we ran out of time, so we have to proceed for the last thing. Thank you very much.
We so nicely.